Thank you. Thank you for the introduction. So, Cato Grønnerød, as you said, Associate Professor, Department of Psychology in Oslo. I have been doing research on personality and personality assessment mostly, but then also ended up in psychedelics. But what I'm trying to do here is to draw the concept of personality into psychedelics. So that's my sort of main project in a way. And also focusing on negative effects and what determines negative effects. So let's see if this, no, is this working? Now. There you go, thank you. This may sound a bit technical. I'm going to hopefully simplify the whole thing and make it more understandable. But we have been doing some surveys at the University of Oslo in the psychedelics research group that we established a couple of years ago. And I'm going to present those and extract some data from those two surveys today. So I'll introduce the surveys, do a bit of advertising on those. I'll explain the concept of level of personality functioning, in case you're not familiar with personality psychology. Then to see how we defined negative effects in these surveys. There were specific questions, obviously. And then present the results and some takeaways, I hope. No disclosures for this particular study, all internally funded. For those two surveys, there were some disclosures that you might want to look up. Okay. The onset of the whole study is based on the fact that the clinical studies have quite strict selection criteria for their participants. And they do this obviously for safety reasons, but it also means that we gain less knowledge on how psychedelics and MDMA work for people with more severe disorders. So we're looking at people who report their recreational use of these substances to see if we can learn something from that. The clinical studies also are very strict in their application of diagnostic conditions, obviously. And especially maybe for the more severe conditions, do we see any improvements also there? And how much negative effects do we see? So we hope that this will inform future expansion of clinical studies. Okay, so the general question that I'm asking for this presentation is whether personality structure can determine the quality of psychedelic and MDMA experiences and how the participants deal with these experiences. And the specific question I'm trying to draw from the data, whether people with more fragile personality structures, as measured by the level of personality functioning, is more vulnerable to experiencing negative effects. And negative effects in this context is we call it negative, we call it adversive effects. They can also be challenging effects. And I'll come back to that. We measure this in different ways. Now, challenging might not necessarily be negative, at least not in the long term. Another thing that we're trying to draw from this data is to look at people who use only one substance versus those who mix. And this is the first step in what we hope to present as a full article and a full study. So we've been playing around and thinking a bit about the concepts and what kind of data to use. So this will be one small piece of that study. Okay. The first study that we published in 23 was a recreational use of psychedelics survey. Anonymous convenience sample, so it's quite a selected sample, obviously. Plus 18 years, fluent in Norwegian, and we asked for a memorable experience with psychedelics. And obviously, people would not necessarily respond to just one experience. Maybe they have a sort of a generalized view of what an experience is. So we don't have full control over that, but that was what we asked for. We had 770 respondents in the final data set, which was quite good, we think. We got quite a lot of traction, especially at the Rusopplysningen, which is a drug information site that presents quite neutral and objective information about drugs, their effects, and also advice on how to use the drugs safely. So we had a pop-up ad there, and I think we don't know exactly where they came from, but this was a major source of recruitment. So that's the first one. And then the second, we did the similar study, almost identical, with MDMA. So the only thing that we missed here is ketamine use, right? So we had this classic psychedelics, quite a wide definition of that, but excluding ketamine and MDMA. And here we have the MDMA. Same strategy. We got 608 participants for this one. Published last week. Yay. With some errors in it. Some figures have been switched at the proof desk. Not happy about that. Hope you'll see that if you go into it. Hopefully we'll get it fixed. So we have two quite similar surveys. And I'm trying to pull them together for this particular study. The things we had in common with demographics, use patterns, like how often, last year, lifetime use, but quite a lot on the characteristics of the memorable experience, set and setting, quite a few questions about that, acute and persisting effects, both positive and negative. We asked people to evaluate whether they had a mental health condition or a disorder. We had a list of categories. We also asked whether this was set by a physician. I think about 40% said yes, and the other 60% were sort of self-assessed mental disorders. So again, it's not official diagnosis, but at least an indication of what kind of mental trouble people felt they were in. We used the emotional breakthrough inventory, the challenging experience questionnaire. Those were the common ones. And then for study one, for psychedelics, we used the ego dissolution inventory, which we felt was suitable for psychedelic experiences, and then the psychological insight scale for the MDMA. And then finally, I managed to persuade my colleagues to include the level of personality functioning scale. In the second study, I was not successful in the first round. There's always the question of how many questions do you put to people. At least this time I was successful in putting it in, and that made this study possible in this sense. So what is level of personality functioning? You can say in general, it's a global measure of mental dysfunction or mental disorder. And it comes originally from Otto Kernberg, who is an important psychoanalytic writer. And his concept of level of personality structure or level of personality organization, which is divided into three basic levels: neurotic, borderline, and psychotic. We are most of us in the neurotic part, which is a basic tenet of psychoanalysis. We are all neurotic. But depression, anxiety, that kind of mental disorders, borderline, is mostly about personality disorders. And then you have the psychotic disorders. So this is a level, and it's a level of impairment. So the more impaired you are, the further down this scale you're going. An interesting thing about the DSM and the ICD-11, the diagnostic systems, is that this way of thinking is returning. So the alternative model for personality disorders, criterion A, is based on the same thinking. So there's a scale there that measures level of personality functioning. Same thing is coming to ICD-11 in a bit more simplistic form. We use the level of personality functioning scale brief form, which is just a 12-item questionnaire. This is modeled, by the way, on the DSM criterion A, the way of this is conceptualized. So We defined negative effects as, have you had experienced persistent negative reactions after the psychedelic or MDMA experience? And then we asked about duration for those persistent effects. What persistent negative reactions have you experienced? Then we listed quite a lot of somatic and mental problems that you might have experienced. We added a few, always wiser in the second round, had a few more in study 2. Did you have to seek professional healthcare? I'm not going to deal with that question right here in this study, but we also asked about that. Very few people said they have. And how severe were the negative reactions? Didn't bother me, up to severe. And then there's a challenging experience questionnaire, right? And coming back to what I said in the beginning, challenging could be negative, could be passing over to something more positive and constructive. Okay, just to give you an overview of the studies and what people report. This is the number of diagnoses that people report in study 2. It's very similar in study 1. By the way, we expect that quite a few of the same participants were in both. We don't know who because it was anonymous. So there is an overlap here anyway. But you see, 110 had no diagnosis at all, no condition. So you can see that it's a quite burdened sample, both of them are, in the sense that they report quite a few diagnoses, up to 13. I guess that's one person who felt very bothered. That's the number of diagnoses. This is the rate of change that people experience this is from study 1, the psychedelics. The green bars are perceived improvement in each of these conditions that people reported. The pink ones are worsening, and the blue ones are no change. I think this is quite impressive in itself. People report quite a few symptoms, disorders, and then they also report this much improvement. And this is only recreational use, right? PTSD has the highest rate, also depression, the lowest for smoking, and ADHD. Similar pattern in study 2. PTSD is also the one with most improvement here, suicidality and depression. And then again, smoking, not much improvement there. But these are really good results in themselves, right? So even if people have troubles, they feel that this is helpful for them. Now, also quite interesting, I think. In the 2 studies, about 60% took only one substance for what they reported as a memorable experience. That could be several, but still. 60%, also a marked difference in whether they combined with alcohol. 60% with MDMA, quite common. That's of the remainder of the sample after in the 40%. The mix of those two, not so high. Okay. Also, just quickly on the amount of negative effects that people report before I come to the level of personality functioning connections. You see that most people, or the highest, reported no effects, no negative effects, or only transitory, like only a few days. And the same with if they reported negative effects, it didn't affect daily function. So it was transitory, mostly. This is the challenging experience questionnaire score. You see the highest frequencies on the lowest ranges. So people are not that bothered. And also the number of reported persistent side effects is quite low. Okay, because I didn't have the LPFS in the psychedelics sample, I made a proxy based on weighting of diagnostic condition. It works. There's a correlation of 0.58. It's not perfect, but it's what we have to go. Okay, so these are the main results here. The duration of negative effects, low correlations. Severity of persistent negative effects, low correlations. Significant, but low. Challenging experience questionnaire, also quite low. A bit higher for the MDMA sample, but still not very high. And also the number of persistent negative reactions, which we missed data for in the psychedelics part. If we look at this separation between the 60% that had this pure experience, there's no difference for the psychedelics, no significant difference between these. If we split the sample into mixed and pure. But for the MDMA, we have a significant difference in the persistence of negative reactions. So there we have those who only use MDMA. There is no connection basically between level of impairment in personality and MDMA use and these persistent negative reactions. So the overall finding is that we have short-lived, manageable experiences. There's a tendency for moderate to large effects for MDMA. So it seems to be that at least for those who mix substances, there is an increase in negative reactions, but there's very few negative reactions in the pure sample. So maybe there's also, that means there might be a connection between level of impairment in personality and the use of mixed drugs. So that's the one kind of one of these connections that we have to explore further on. But basically, there is no clear, or at least not very strong, connection between poor personality functioning and negative effects. This could mean that we could widen our scope in the clinical studies to at least slowly include more diagnostic conditions. The minuses here, we have self-selection. Obviously, these are people with positive attitudes. We probably have more people with less negative and more positive experiences as a selection. So those that completely freaked out during their experiences weren't responding as much. Self-report is always a limitation in these kinds of studies. But we have quite a wide variety of users, settings, motivations, mixing or not mixing with other drugs, certain settings, which is an important thing that we want to explore further. And we hope that this might inform the future use or the future expansion of clinical studies. So that was it for me. Thank you.
Thank you very much, and we will have plenty of opportunity for questions. I will ask, because I'm holding the microphone, I'm going to do the first one. Can you look, or have you looked about the connection of personality to the positive effects? Like there was a lot of reporting of improvement in their conditions and disorders. Is there anything?
No, not
there?
yet. So
Okay.
We'll look into that as well. Obviously, yes.
But I will pass the mic over here.
Thank you for a great lecture. So I was just wondering, it was a pretty big difference between the data in the first study and the second study in terms of positive effects. You saw similar patterns, but it was much more positive effects frequency, or a higher positive effects frequency in the first study. Do you have any ideas why?
No, I'm not sure. We need to examine that as well. Other than maybe because the CEQ scores were fairly similar in their average scores. So if you look at that side, it seems that there's about the same amount, but maybe they are distributed a bit differently. And then if we also need to look at the positive sides, which we haven't so far. So anyone's guess or evaluations on that one?
Thank you. Any other questions in the audience? Everybody's feeling tired after lunch, a bit of an after lunch dip. Here we go.
Yep.
Hello. So certainly it has to be subject because it's a questionnaire. So it has to be subjective and even biased in some sense because sometimes we can see people doing some maybe dope and they say they are themselves fine, but the others around see that they are not fine.
Yeah.
So they don't realize themselves what's wrong with them. For example, like paranoia or lower ability to go to work.
Yes. On the other hand, people report quite a few conditions and symptoms, and they seem to be, at least there's a lot more than the general population, normal population. So in that sense, maybe they are being quite honest, but that is an obvious problem in self-selection here. But I think since we have so many that report so much, it's also a selection towards those that are struggling and that they feel that they need some kind of help. But the realism in this, we can't assess. No, it's self-report.
I was wondering when you said that we should widen the scope who we take into the psychedelic assisted therapies. I was wondering that there was in the MDMA, at least for psychotic people, that it was a risk, that some people said that it made it worse, but bigger part who said that it made it better, their condition.
Yes.
So what do you think? Should we explore more taking psychotic people into the trials that most could benefit?
I would expect set and setting to be quite important. So I think that's probably the major thing we need to explore, whether a safe and calm setting will make people experience at least less negative effects. So there's a lot of things we need to look into here. This was just the very first extraction of data from these two studies, these two huge surveys.
Anyone else with a burning question? We have another one from the gentleman in the back.
I love your announcement, Alexis. It's like, you're like an auction guy. Another one for the guy in the back. Yeah, so I was wondering, how would you construct a study like that, where you like look into different settings? Would you do a naturalistic study and like look at different settings that people took these drugs, or would you do like a clinical study with different groups with more or less conducive settings?
We have lots of data on set and setting in these surveys, so it's just a matter of connecting the experienced effects with the settings. So, like for instance, whether they had a therapeutic or recreational motivation for taking the drug is one important thing. Whether they did it at home, at someone else's home, whether they were out partying, different questions around certain settings that we have already.
But you haven't looked into...
No, that's the point. There's lots of data in these two surveys. There's loads of data that we need to dig into, and this is one of them.
All right, this is starting to be one of their last opportunities to ask a question. Any takers? If not, let's thank again for a great presentation. Thank you.